And for those who missed yesterday's sessions, this is my second sessions. My name is Dr. Moses Deng Malwal. I'm from South Sudan, working for Minister of Health as Director General for Pharmaceutical and Medical Supplies, and as well a board member for South Sudan Drug and Food Control Authority. I'm very glad to be part of this panel as a beneficiary of a global health initiative in South Sudan, where our partners are supporting the health sector and investing in the health sector. I would be more glad to share some, experience during this discussion. Thank you so much.
Thank you, Ms. Moderator and colleagues. My name is Oscar Hogo. As you are told earlier on, I'm the CEO of East African Chamber of Commerce, Industry and Agriculture. That is the apex chamber for our Eastern Africa community member states. We have Kenya Chamber here, Uganda, Tanzania, Rwanda, Burundi, South Sudan as well. We also work with Mozambique, an Ethiopian chamber. And mainly our work is actually to coordinate what they are doing in support of their membership basis. I'm also, as the East African Chamber itself now, a vice president of the Africa Business Council. Africa Business Council is an African Union body which was created at the same time that our heads of state created they said they wanted to boost intra-Africa trade, and they said they want to have the continent as one common market. I'm sure you are all aware of the Africa Continental Free Trade Area. Those two institutions, the Africa Continental Free Trade Area Secretariat and the Africa Business Council, were created at the same time. AFBC, which is where I'm a vice president, is supposed to rally the African private sector together so that we are able to implement that agenda of getting the continent trade more with itself. Instead of importing goods and services from outside, we need to have internal capacity as Africans to trade more with ourselves. And that brings us around to the issues of health as well. I'm sure our colleagues, our partners from outside the continent will not be happy to hear that, but I think we can only be good partners if we have also equal capacity, more or less a similar capacity. Currently, that is not the case. Of course, that is what we want to address in the coming years. Africa has an agenda of its own, while Kenya has an agenda 2030. The continent has the agenda 2063. I think we are getting there. We have more than 40 years to go, but I think there is a long, long way to go. And health sector is one of these agenda items that we need to make sure that we promote and we strengthen so that we have enough human resource capacity to be able to drive all the other factors that we need, the economic agenda and everything else. So that is myself. I think I'll be talking a bit later on that. Yeah. Thanks.
Good afternoon, everyone. My name is Damian Wanderer. I am a trade and investment advisor with the United Kingdom's Department for International Trade, which is under the Foreign and Commonwealth Development Office. My role is to promote foreign direct investment and trade from UK to Kenya and vice versa. And just to bring up a point that previous speakers have raised, as a department that consists of 6 Kenyans out of 70 members, we are very keen on advising British investors, British companies, to make investments that make sense for us as people. So mutual prosperity is at the top of our priorities. And we are keen to ensure that we benefit from research, we benefit from knowledge exchange, we create jobs for our people from the foreign direct investment coming from the United Kingdom, and we trade more. We actually do things that make sense for Africans, not only just for the UK. So I do cover healthcare, education, and technology, and my background is in private equity in East Africa.
Good afternoon. My name is Dr. Abdi Mohammed. I'm a co-founder and CEO of Labnan Hospital.
You decided to go with a few words there, but we'll come back to you. So I would like, first of all, to start off with Mr. Charles, because I think you have requested that you might be leaving us, huh? But I just need to get an understanding of the funding ecosystem and the way it plays out vis-a-vis healthcare. There's a current meeting going on organized by the United Nations Sustainability Development Goals, SDG. And if you look at the investments that are coming into Africa, FDI, 50% of all investments are going into tech. And about 50% are going into tech. And then another huge percentage is going into energy and agriculture. But there's this paucity of investments in healthcare. What are we in the healthcare space potentially doing wrong that we are not attracting these investments? Or rather, I can put the question another way, what should we be doing so that we can attract more investment into healthcare in Africa?
Thank you for that question. I think it is it's the right time for you to ask it. But from the private sector perspective, I can say that the private sector can invest in any sector of the economy, anyone, including health, if they can foresee a return. Of course, that is the bottom line. You can't invest money where you know that you're not likely to get it back. And how then does the the health sector, in fact, try to attract that private sector money that we know we have in abundance of? It's a lot of money actually floating out there. In fact, sometimes we do not understand why the government has to excessively go out and borrow money at high rates of interest. And secondly, at conditions that are actually more or less so impunitive that, is not normal. Whereas the private sector has that money. So where do we start? First of all, it is an enabling business climate that must be in place. Health sector itself, we conceive it as a risky sector. And the government must actually change that perception by the private sector that give me a second to just put it off. Sorry for that. The government must actually come out clearly to see that they make the environment enabling, particularly in the health sector. We can come there and invest money. And I like what Professor Rogo talked about, that the public-private partnership is the way to go. We have actually, Kenya is endowed with actually good cases of private sector actually investing in health itself, but that is where they make the risks themselves without the government intervention, and that's why you are seeing it is slow in being accessed, because there are only a few sectors. Nairobi Hospital, Kenyatta is a public hospital, which, in fact, that lady, Olive, Professor Mugeda, was actually trying to do a PPP on that one, bringing the private sector money to support government investments. That is doable, and it's something that we can actually be able to benefit from. But as I said, enabling laws that would attract the private sector so that they consider health sector less risky to put their money in and be able to get a return, because it has to come back. You put money in to know that at one point you bring it back. That is not in place. I can actually quote cases here myself I have discussed with the government One other issue I didn't say that I'm good in public-private partnerships, agenda. That, in fact, I was involved in its enactment here in Kenya. Early in 2012, I think that's when the finally Parliament passed it as law, with the amendments that we as the private sector had proposed. But the problem has been the way we are implementing that law. It is anchored around the Treasury, the PPP directorate there. And for it to benefit the country, it has to be cascaded down. And we talked about actually the devolved units, which are now the counties. The counties today haven't got mandate to implement PPP projects unless they are cleared with the Treasury. And then, of course, the private sector, which is domiciled at the counties and can actually support the counties to do some of the infrastructure investments for health, cannot do a thing. This is something we are ready to do as private sector. And I can tell you, the current president of Kenya Shimba, is actually a person who invests heavily in health. The reason why it is not moving ahead is because some of the laws that we have in place cannot be actually applied. I have talked with Mombasa County. I think that one is, Governor Joho is actually a person who thinks a little bit out of the box, and I think he is trying to go that direction. Kisumu, I'm sure Professor Anyang' Nyong'o can do that, and I know because the PPP agenda started with him earlier, and I was involved in that. And that's why Professor Rogo said something is happening in Kisumu, which is really good. But this one-off cases is not what is going to actually bring about universal health care support systems, including now the health infrastructure that we need to build. The private sector can help build the health infrastructure that we need, the institutions that are required, where the government comes in, and that's where a sustainable partnership is actually supposed to happen. The government comes in and provision of what you call the software, the doctors and other people. The private sector is ready to do that, but are we at the public sector feeling challenged enough to work with them as partners? And they have to be equal partners, because a partnership which is one person thinks he is the only one who can call the shots is not actually a sustainable one. We cannot actually invest money in that kind of a partnership, and it's bound to fail. So, to cut a very long story short, I think what we need is an enabling environment, the government to consider the private sector as an equal partner who can provide what you call social services, which is a mandate of the public sector, to support that sector, public sector, to supply the service needed by its own citizenry. I think that common understanding is not there yet. We talk about PPP, but it is just not happening. And the private sector, as I said, is not going to put money where they think the investment is risky. Health sector is a bit risky. But we can apply actually our resources to build hospitals, to build schools. These are purely public sector, it's supposed to be public sector investments, but we can build that jointly with them, on the understanding that the government or the public sector will provide the other software that is required to make sure that the institutions are running. That means if it is in a school, you provide the teachers and all the other enabling environments. The private sector will build the facilities, the classes, classrooms, and so on. And you allow them at some point when they can recover their money, in fact, to exit. That is something, it is one of the models of PPP that we are not really looking at fully, because we are talking about public-private partnerships, including infrastructure like this Nairobi Expressway. We do not see, because so far, and I told you I'm an expert in PPP, I have not foreseen the benefit of our government. it is, well, let me not go there because I think it's a sensitive subject. But some of these things you do, the private sector can come there and build that road. In fact, we have been actually advocating that we allow the private sector to go and build the roads. But they must see when they are going to recover their money. And the kind of contractual agreement that you go with into them must be that, transparent, and you see clearly that there is not going to be some shoddy deals along the way, and you lose money where you have sunk maybe 1 billion shillings, and you don't see when you return it or recover it. That is the same thing with the health sector, I can tell you that. Or other social sectors I've talked about, schools and so on. In fact, the discussions I've been having with some of the county leadership is why are not mobilizing the private sector in their own counties to support them to put in place some of the investments, developmental investments that are required in those counties. And then they agree on how the private sector is going to recover the money. Yeah, that is a subject that we need to talk about. And for Kenya, in fact, Kenya, we are very lucky because these devolved units, as Professor Rago talked about here, they are the best delivery vehicles for development, the best. And you can, in fact, attempt to kind of say, I'll try to deal with what you call healthcare delivery system using the private sector, Mondo, where they can come, provide the facilities, and the government comes to provide the other issues, and we see whether it will work. The investment will not have been so much, and you can see whether there will be impact. I would rather we go that route, in Kenya, and see then, consequently, you can go and, starting with Nairobi, then go to Kiambu, wherever else, move on like that, see whether the private sector will be attracted enough to invest in the health sector. For me, I'm ready to kind of support that, because that is one agenda that I like to deal with, to support the private sector move to work together with their own governments. Even here, in fact, we discussed that issue. That one we were talking about something else in Dodoma last year. I was there and I was talking. And I mentioned to them that some of these investments they are putting so heavily, very heavy investments, they can use the private sector to come and work with them. And then most of the money they are investing in as a public sector can be applied to other uses. Because government use of money is huge. It's a lot of money. They have to build schools. They have to build sometimes markets. They have to bring about BRT in a city and so on and so forth. If they can see some of those components that can go to the private sector and they get into a proper PPP arrangement, they will get savings of the amount of money they would have put in there to apply to other sectors, build more health facilities, build more schools, and so on. So, in essence, the private sector is ready to come in to support health sector delivery, put an enabling legal environment which assures the private sector that the investment they are going to make is going to be recovered, and it is not in a risky sector. Health sector currently we actually think it's a risky one, but it can be actually turned around depending on the way the government wants to perceive it, and in fact, if they want to genuinely attract private sector money. I think can stop it there for now. Then,
in fact, I would like to jump on to one of the points you have mentioned at the very, very beginning. I've been in the health sector now for a number of years, and I can tell you, I have tried a number of ventures, and the biggest challenge has always been access to funding. At the very beginning, you actually mentioned that there's a lot of money out there that should be coming into healthcare. And probably now to ask Damian, as you mentioned that your office is about bringing money in. Just give us an idea of the scale of what you're talking about in terms of what is available for the healthcare sector in Africa.
Great, thank you. So just to give a snippet, let's say development finance. I think everyone is aware of IFC and what they do in the healthcare space. So development finance institutions are concerned with private sector-led development. So they're more focused on supporting private entities to be able to scale, to be able to provide employment, and actually drive economic growth in their countries. And you'll see a lot of development finance institutions are focused on Africa and Southeast Asia, because this is where you have least developed countries. So just to give an example, the United Kingdom's Development Finance Institution, which is actually financed by taxpayer money from the UK, last week just announced an equivalent of about 870 billion Kenya shillings for Africa. And the CEO who was in Kenya last week mentioned that the target for Kenya is about 10%. So that's about 87 billion Kenya shillings that's available in the next 5 years for investment. And this is investment that is into private sector entities in the way of an ownership stake, so equity, and also debt. And as you know, development finance institutions do give patient capital, and they're very flexible in terms of how the money should be repaid and how the transaction itself is structured. So that's one of the pockets of funds that I can say is available, and that in itself it's massive. Again, United Kingdom is keen on responsible investing, so anything that has social impact as well, and healthcare definitely ticks all the boxes. Anything that saves the climate. So having innovative ideas such as innovations in healthcare that are powered by solar, and such kind of things, those will attract investment. Now that's development finance. If you think about private equity, there is actually a lot of money as well in private equity. In fact, East African private equity fund called Ascent Capital, I think a few days ago announced they had acquired a majority stake in Valley Hospital in Nakuru, and which is a medium-sized private hospital. Before that, they acquired a stake in Diani Beach Hospital at the coast. So that's a private equity fund putting money in healthcare, and all those are recent deals. If you look at the Africa Venture Capital Association, in 2018, just about 4% of their deals were in the healthcare space. But in 2020, that jumped to about 24%. And now after COVID, that has even gone even higher. So, private equity firms like Ascent Capital, who have raised $100 million, that's about 11 billion Kenya shillings for their Rift Valley Fund 2, that's a lot of money that is available to private entities, and of course DFIs as well. Then I think the issue is that most players in the healthcare space are only aware of the traditional ways of providing funding, which is, say, getting budget from public resources or government budget, or getting donor funds, or getting maybe debt from banks. Now, as we know, for example, in this economy, banks are giving a lot of their money to government because it is risk-free, and the rate is favorable. So government is crowding out private sector in terms of getting credit, and that's why you get the likes of medical credit fund coming in to step in and fill that gap. And so traditional finance proves to be a challenge for healthcare firms, especially because it's just deemed to be risky. Banks will not be looking at it very keenly. Of course, you have budget constraints, and when it comes to donors, donors are also facing budget constraints in their own countries, and so they are cutting back on aid and focusing on something more sustainable like trade and foreign direct investment, where as much as their money will flow into this economy, they'll still get back a financial return. So when you rule out those traditional sources of finance, or when you exhaust those, now you start to look at the non-traditional ones, and that's where private equity comes into play. As I mentioned, also development finance institutions, then venture capital. Actually, it's interesting that a lot of corporates, the ones you would call the big boys, like the GEs and so on, they actually have an arm that supports early stage companies. So if you do have, innovations in the healthcare space that GE feels will be complementary to their business, and they feel that they can acquire your business in the future because it has profit potential and so on, they'll be willing to bet significant amounts of money on those startups at a very early stage, because they know that there is a long-term positive potential from that. So private venture capital, also driven by the big corporates. That's an area that most people are not aware of. There is as well impact investors. Some of impact investors are not looking for a high return. They are more focused on a social return than a financial return. So those again are a good source of money for entities in the healthcare space. And there was a mention of blended finance in the previous panel session. Again, blended finance really by definition has many forms, because it's catalytic capital, mostly from philanthropic as well as public sources, which comes into projects to de-risk them. So this can be in the form of maybe guarantees given to private parties. It can be in the form of technical assistance facilities, which actually help you to bring out the commercial viability and de-risk some of these opportunities and attract private capital. So that's another area that hasn't been explored fully. And maybe finally at public-private collaborations and partnerships, where we've had a lot in the previous sessions. So one of the challenges when it comes to these PPPs is budget constraints, or on the public side of things. And now there is a way to go around that. For example, the United Kingdom offer is around concessional finance. So if we do need to put up a facility that costs a lot of money, and government is not able to get the money for that from budget, this money can come from, say, UK Export Finance, which is the export credit agency. Now the limit for Kenya is up to £2 billion. That's a lot of money, and that is that can be in the form of buyer credit. So this is credit that's just being given to the buyer of services from the UK, and it doesn't have to be 100% from the UK. The threshold is just 20% content. So if you do have a project that's getting 20%, it's meeting the threshold of 20% content from the UK, could be in terms of medical equipment. It could be in terms of maybe design, if a professional from there is doing that. And you then fill up the 80% with content from your own local economy. That money can be unlocked, and it's unlocked even easily when you have a sovereign guarantee from Treasury. So those kind of financing sources are what we are trying to highlight to the relevant stakeholders, healthcare entrepreneurs, governments, and just telling them, look, here is money that works for you. For instance, UK Export Finance, the rates are really low. I think it's one digit financing, probably in the 2% range, and that can be even as long as 10 years. And you have, if it's a project that requires construction, then you have a moratorium for the period of construction. So it's really attractive, and it comes in to fill a gap, the gap that you have that is brought about by budget constraints on the public side of things. So that's just a nutshell of the financing sources that you have to scale up things in the healthcare space.
Thank you very much, Damian. It comes as a shock for many of us who are practicing clinicians. Maybe the front row of business people, those kind of numbers don't shock you. But when you hear that we have 87 billion shillings available for us for business ideas, it comes a little bit as a shock to the system. But at the same time, now I want to jump over to Dr. Allen. Initially, when I was reading your profile, you have a very impressive profile in terms of governance as well as financing. But it's something you said that actually piqued my interest. Something you just said when you're introducing yourself about bringing the diaspora to actually work here in Africa. I know this might be a little bit of a curveball, but the largest source of financing into Africa over the past few years has actually been diaspora remittances. And there has been this lack of mechanisms and structures for them to be actually directed profitably or in a manner that is can be termed as an investment. So with your experience in the healthcare sector, as well as you're talking about biotech, and also the fact that you probably know the diaspora pretty well, how can we channel these resources from the diaspora, not only financial resources, but also human capacity to actually support the healthcare sector in Africa?
Thank you. First, I would encourage you to sign up at allafricahealth.com. And I certainly can share more information with you about that. But the reality is that the diaspora has always been involved in the continent, throughout the continent. In healthcare, let's go there. Africa CDC. In 2019, I worked with Dr. John Ngingensong, a diasporan from Cameroon, who ran the Africa CDC. He mobilized several events to encourage diaspora to get involved. So I think, first of all, I would say it's a welcome. It's a karibu. The president of Ghana has done that very well with the year of return. Throughout the continent, we haven't had that. And so I think there has to be a formal outreach to say you are welcome here, and Kenya is open for business. East Africa is open for business with the East Africa Chamber of Commerce, for example, which is in Texas, which is East Africans in the U.S. of various fields, from various fields of endeavor, who are ready to engage. That's one. So I think the outreach. What Dr. John Ngingensong also did was that he got the right people around the table to help, meaning capital providers. And so I think the second thing is to connect with us who are here, who have these connections with capital providers. There are lots of institutions now that are managed by people of African descent historically and on a contemporary basis. When I make that distinction, historical diaspora, I mean those who largely went to America from Africa involuntarily, right? Like most of my ancestors. And those who are contemporary diaspora are first and second generation immigrants who are there now. We think that's an artificial difference, right? Largely meant to divide. And so we say, look, it's very important for not only have these connections on the ground, but connections to capital. So two institutions that manage a lot of capital that typically serve and are comprised of people of color, National Association of Security Professionals. They're largely known for their work with Power Africa in funding infrastructure. But that could shift with a proposal, because these are pension fund managers, advisors to asset owners in the U.S. who are looking for exposure that would diversify their portfolios. The other is an institution called the National Association of Investment Companies, private equity and venture capital companies. The challenge is largely their remit is to not invest overseas, but that's changing now. They do have a couple of members that are part of that constituency there, but also invest in Africa. One of which is a large infrastructure, again, investor, which now has shifted its focus to pharmaceutical manufacturing as well as a part of the infrastructure equation. But I think the biggest win right now will be when it comes to collaborative efforts around technical capacity. Why do I say that? Investment typically in different sectors has followed where there has been a proven production capacity, where there would be, some assurance on return on investment. Throughout the continent, most of the production capacity in Africa has come from abroad. Now there's an emerging effort for that to be more locally based. And so that now is going to attract more capital. But here's the connection to the diaspora. Part of it is making sure, as others have said before, that the initiatives are locally driven. Diaspora are important for that because diaspora will come in and get behind local driven efforts, partly because of sociology, the lived experience of knowing what it's like to not have the autonomy to do that. And so the sensibility will be, we need to come and partner and support rather than come in as even a black savior, right? And so that's very important. The other piece of it is the technical skill. One of the things that we're really excited about with this alliance is that we have Morehouse Medical College. One of the professors already signed up who has a specialty in oncology and is willing to mobilize investment, other resources to bring into the continent. But I also would say this, part of it is the connections, this is outside of Africa, but the connections that need to happen within the diaspora communities in America or in Europe. It's not always the case that you see diaspora communities working together. And that has to change because there's so much to be gained, not just here on the continent, but developing those relationships in America so that there's familiarity with the continent and a curated partner to bring them in. And so those are the areas I think that are very, very important. The last thing I'll say is this. I think that when it comes to just the access to capital in general, some of that has to start at home as well. The opportunity now in technology is just not in fintech. It's just not in ag tech, but it's also in health tech. You'll have John Kamara, I think, on the panel later today who will talk about a FIA record. And there are other technology entrepreneurs from Kenya, from East Africa, who are pushing but don't have access to capital. And so one of the solutions there that we're trying to facilitate here in the diaspora is an angel investor network, which will present another category of capital for more early stage or pre-revenue stage companies. And that's really important when it comes to technology investment. And then along with that is the policy initiatives to really now create the enabling environment, but also to be able to attract capital throughout the life cycle of capital provision. Angel, VC, private equity for growth, and then exiting to maybe the capital markets. And, when it comes to something like hedge funds, which I know was part of the agenda to talk about, my reaction was that maybe is aspirational right now because hedge funds invest in healthcare across the world, particularly in infrastructure to a very large degree. But on the continent, they would, when I say infrastructure, it's largely pharmaceutical. But on the continent, because there aren't these large assets that will attract hedge fund money, that points to the need for the capital markets as part of this equation, angel, VC, private equity, capital markets, to also be supported and to also be encouraged to expand. And I think we are on the way. And last but not least, I think that now with the emergence of COVID, and as we are still in the throes of COVID and post-COVID recovery, there is a heightened excitement, I think, interest in investing in the continent. And so I think one of the things I would say about Kenya relative to other countries is that the innovation is here. And that's something that everyone in the room recognizes, you've seen in other sectors, but it's emerging in health as well, particularly health tech. And that has to be encouraged in institutions like Strathmore, our research institutions, has to be encouraged among the capital providers to come together, public, private, not only partnerships, but first of all, conversations and identification of who are the rising stars in terms of entrepreneurs who have the intelligence, who have the solutions, but just don't have the financial support, because at the end of the day, across Western markets and emerging markets, most of the times investment, particularly early stage investment, is going to be relationship driven. And unless we're at the table, not only discussing policy, but also what are the emerging innovations that are breakthrough, where we have the talent in place or can recruit the talent to actually push those innovations forward to commercialization.
Thank you very much. And just to put it on the table, that one of the biggest, the mission of Open Fences is actually to start supporting the building of those relationships between government and the private sector and all other ecosystem players. So they start discussing where are the innovations, who are the funders, and that. Now,
can I make one more plug
yes.
to add what Damian has said? There's a new fund emerging, and that's Transform Health Fund, which is managed by AfriCinvest, which has a presence throughout Africa, Sub-Saharan and North Africa. It's a $100 million fund that's emerging, and the Health Finance Coalition is a partner with that fund doing deal construction. So this is another innovation in terms of capital provision, where deal construction is happening by a group of experienced investors, management consultants, transaction advisors, to provide a pipeline of investment opportunities for this larger fund, which I think was targeting first close this year and final close next year. But that's something to be on the lookout for, because there aren't many health-focused funds. For a lot of the DFIs and fund of funds that provide capital to funds, that's transgressive, meaning they don't want single sector funds because of the risk involved. But I think what we've seen throughout the world the last year has changed some of the sentiment and points now to the need for healthcare as its own sort of investment category now, and that it's diversified. There's tech, there's manufacturing, there's hospitals and clinics and infrastructure. So these are things that are emerging, and family offices and foundations and private donors are now coming together to say, what can we do? So those of you who are innovators, those of you who have large hospital groups that are scalable, that are providing impact, I think this is a great time.
Thank you very much. I would like now to point a question both to Mr. Malwal and Dr. Abdi. And I'll start off with Dr. Abdi. And sometimes when you're in the front line actually working, you actually get to see all these opportunities around you. And sometimes it becomes quite difficult to try and explain to an outsider what the opportunity actually is. So my question is, there's a lot of money. There are a lot of specialists in organizing funds and all that. What are they missing? Because sometimes you come and you're told, first of all, the biggest threshold is ticket size. A ticket size usually of $1 million or $5 million. Yet, I doubt if Kakamega County can absorb $5 million worth of investment at one go. So from your experience, what are some of the things that some financiers might actually be missing out?
Actually, if you think about, there's nothing they are missing. It's too risky. And as you have said, you can't absorb the kind of funds that they have. You can't absorb because most of our healthcare service delivery, speaking on the side of service delivery, is fragmented. You have small players individually. The big hospitals that would have absorbed that kind of fund, unfortunately, are registered as non-profit making in this country. So there's no one who can invest in them. They are all registered as a trust, as a non-profit making, as a religious owned facility. So there's none, unfortunately. So what happens is when these guys want to invest, they look at the second tier. And unfortunately now with the problem with the second tier is they serve the lower middle class and they are fragmented. They are not big enough in terms of size and in terms of capacity to handle that kind of funds. And the reality has been very few of our population were covered. Maybe 3% with insurance, and they would only go to those big hospitals. So sustaining healthcare out of pocket is impossible. If you look at what happened in the last few years when NHIF just made a little change in terms of the money they collect increasing and the benefits that they have added, we had 3 or 5 or up to 10 dialysis centers. Today, we have 250 dialysis centers. So it means it's not that we lacked patients, it's just that it was impossible to provide that service because the cost was too high, and there was no one who could pay 12,000, 15,000 shilling per session for 3 sessions in a month cash, because there was no insurance that was covering. That translates to around 100 and 150,000 shilling. How much rich can you be for you to sustain 150,000 every month out of pocket? It was impossible. So as Kamarogo said, with the coming in of making NHIF mandatory, I think there will be a greater opportunity in terms of people moving now from out of pocket to prepay. That means even the health-seeking behavior will change. That means there will be more investment that will happen in the counties. That means that there will be more specialized or specialists will move to the counties. And I will give you a very good example. I own a hospital in Wajir. We have a dialysis center. Why? Because NHIF pays for it. Why? The patients who would have come to Nairobi and stayed in with relatives and go to KNH now have the ability to stay behind. We have set up a theater that's capable of doing laparoscopic surgery. A surgeon has moved in and stays in Wajir and does, because NHIF also still pays for surgical packages. That is the only thing. And once we address the healthcare financing model, then everything else will fall into place. There will be a few challenges here and there in terms of policy stability, because without that stability, it will also be a challenge for any PE fund or anyone who wants to invest to risk, especially if it's a PE fund that is supposed to give returns, because that money is not free. When a guy is giving you $20 million, $10 million, there's someone who has given him and is expecting 5% return in the next maybe 5 years or 7 years, guaranteed. So he also has to make sure that wherever he's investing, there is an actual return. So when you have this kind of policy instability where things go haphazardly, someone seated in Ministry of Health or NHIF decides comes up with regulations that don't make, without consulting any sense, then you will run into trouble. And when you have so much regulations, so many licensing agencies that don't add any value, you will also push back people. So it's to de-risk and in the end, combine as many facilities as possible so that there's scale in what you are doing.
So consolidation of the sector, similar to what we saw about 5-6 years back with the pharmacies. Then
even in banks.
Even banks. We actually saw that happening a couple of years back, going back to the issue of de-risking our healthcare sector. Dr. Malwal, from your perspective.
Yeah, thank you very much. Investment in the healthcare system is not only to save life. So we have to change even the mindset that is only to change it to save life, but it is also a crucial investment in the whole and wide economy in any country. I'm leading to that concept because when I mentioned the global health initiatives and the support from our partners in the health sector, I have a good example in South Sudan. What in their mind always is to come and support the country in the provision and delivery services in the country to attain the goal of, reach the outcomes in the health sector. But the area of sustainability is not there. And if you can recall from Professor today, our problem in the healthcare in Africa and maybe in South Sudan are very clear. You have to address this problem first, before coming in. One, the issue of human resource. In some countries like South Sudan, we say inadequate human resource. We don't have human resource. In the case of Kenya here, there are human resource, but they are not well utilized, or for any reasons. The second aspect also is the issue of poor, resource allocation to the health in any country or regions. And the third one was talk about the issues of, the political will, when he was talking about the allocation of resource to the lower levels. And as well, the maintenance of the healthcare, system infrastructure. These are the area of concern. If you are coming in for investment, you have to invest in these 4 areas. And these are the areas missing by financiers always. For instance, in South Sudan, we have 2 projects in place that funded by our partners in the health sector. We have 10 states and 3 administrative areas, like the way counties here. That funding all, the service delivery, starting from the service delivery, provision of basic and medical supplies across the country. But when you come into the system, although we have policies, you will find they are not aligning themselves with the policies, with the national policies. I think it's a concept also have to be considered. You have to align yourself with the priority of the countries, with the policies of the countries. You work very hard also to integrate all the activities with the country policies and country activities as well. You have to harmonize for the sustainability because they are not going to be there for years. And that's why sustainability is extremely important to be considered as part of missing, areas in financing of the health sector in any country or the regions. This is what I can share with you. So thank you so much.
Thank you very much, Dr. Malwal. And finally, last but not least, AMREF. It's very interesting to have watched the journey of AMREF. From, you're not a CSO, you're an NGO?
Yes, we are.
NGO, yeah?
Yes.
So it has been interesting watching the journey of AMREF from an NGO, and now you're moving actually to service provision. You have education coming on board. Huh? What has guided this journey now to the point where you're actually sitting on this panel talking about funding coming into healthcare?
Yeah, thank you so much. And speaking last after such great insights, you get humbled and you probably even learn, and you start hiding some of the points that you're to talk about. But so the journey has been very interesting, and particularly the revolution in the last 5 years. I think after the conversation of aid, shifting from aid to trade, yeah. We 5 years ago, we've made a bit of strides. I think the same way we've made a bit of strides within the healthcare space. We were 97% donor funded, where if USAID decides today they're going to close because they are one of our biggest donors at that time, then chances are very high we will close. And we saw that directly during the last regime when changes came in terms of policy. But the journey has been very exciting, and I've been part and privileged to have been part of the team that sat down to craft a strategy. 2013, this country was rebased, and I think the rebasing has been going on every time we increase our debt ceiling. So we move and the conversation changes. The repercussions have become very dear, because then the amount of aid you receive really shrinks. And to me, from my own perspective, I don't think the aid shrinks. It's just that organizations are changing the way they're transmitting their funds to countries that are actually that are evolving, Kenya being one of them. So you'd find a lot of venture capital funds, foreign direct investment, private equity, development, or they're called DIBs and SIBs, yeah, the development impact bonds, just to make sure that these resources are not given as donor funded. So as an organization, we took, and the leadership really supported this, we took a deliberate step to actually look where this money is. And if you come to investments in health, just to probably be very particular, the biggest question you ask yourself, where is the money coming from? And I think that's a big question, like the private sector need to ask themselves, where is the money in health? Because I think people look for money in health in the wrong places. Where is the money in health? And who is handling this money? And what is this money going for, to do in health? So as a country, and probably as a continent, being on a transition, then we need to be very careful where we invest our money, because we're still battling with communicable diseases. So still recipients of Global Fund as a country. We are still dealing with questions of malaria, still questions of pneumonia and all that. As much as we've seen significant change and drop in the mortalities associated with that. So we are seeing a rising giant, and something that will eat our strategy, or our Ministry of Finance, Ministry of Health budget, as much as it has increased to about 6.7. It will do that. The non-communicable diseases will chew our budget for breakfast, that I can tell you, if that is not addressed. Then those are some of the areas, just to mention like two, where this money is coming. Then the conversation is, who's putting money there? Conversation around NHIF, I cannot underline. We have 26% of the total health expenditure coming from the household. People still walk to chemists to buy drugs. People still walk to, they do not have any form of insurance. This is driving people into catastrophic. You have to sell everything. You have a car, or you even have, let's even assume you live in Nairobi. Should any of your family member get sick, you get worried. I am in like 5 groups right now in the last 1 week. Please contribute, including 2 for my own family members, who then NHIF becomes a last resort that you have to take when you want to take care. So that's where the money is. The question is, how do you marshal that money to make sure that then the private sector gets the return on investment? Remember, the private sector narrative will never change. It will always be, what is in for me? That's a simple question. I give you this, what do I get? That's a conversation I've had here. I want profit, or I either want that profit in form of impact, I want that profit in terms of whatever they define, could be, and whatever they put in money for. So, and I think it is important to be alive to that, so that then you know where to put money in. And another area that has excited more, has been an area of interest for me, is everybody else innovates in all the other sectors. You mentioned very well, 50% of the money that will come go to tech. And I think healthcare is the last, and I think that's why we were given the chance. Healthcare is always the last in implementing contemporary things. The Constitution, we were still left. People in 2010 went set up their Teacher Service Commission. We were kept busy by a clause who will perform abortion in this country. One simple clause, health professional, trying to define who is a health professional to conduct abortion. The other set up their engines. They don't experience strikes. Healthcare is where you find people always in the streets fighting for salaries and all that. And we are the guinea pig of devolution. There's nothing else that has been devoluted. We are learning from health as much as it's risky and all that. So the space of providing a good platform. I will not insist, as I finish, on the riskiness of, or how people are risk averse in health. We always believe that it's only a healthcare worker who can set up a business in health. You don't believe you're not a healthcare. I'm a biochemist by training, but I tried setting up a lab, and the cost and all that, the regulation was as, I don't want to describe it. So everybody else is risk averse to get into the healthcare space. How do we provide as organizations, and that's one deliberate step we've taken, we are providing a platform or a bed where innovators, we encourage fast people to innovate in health, because no one else was innovating in health, right? M-Pesa, it's the last one. You'll see it will be the last one to get into healthcare. Right now, it's when it's getting in. And Prof has put it very clearly. So it's important to provide that platform. And as an organization, we do provide that platform where we encourage young people to innovate in health. And then we have more than 240 programs that we run across Africa as an organization. So we provide that space for people to come and test, as long as there is value, shared value between the two organizations and specific to the program that we implement. That notwithstanding, I think it's a pleasure speaking to you, and I'm happy to provide further insights.
Thank you very, very much. We're way over time, and I'm cognizant that some of us have not gotten a chance to replenish our sugar levels. But again, I'll just open the floor just to very, 2 questions maximum. So there's one question here. Is there any other question? We'll take them simultaneously and then have the panel answer all of them. There's a gentleman at the back there. So if we could get mics to them, please.
Thank you very much, panelists. It was quite enlightening. My name is James Kamau. I'm from the Kenya Treatment Access Movement and the Coalition for Health Research and Development. I want to ask a very simple question, and I would have loved to ask that question to Professor Ogo, but it looks like he had other engagements. And I would like you guys to address this. And my friend from AMREF has touched on it. When he said health was the last issue to be looked at, even during the Constitution, when others, like education, were going ahead, health was behind. Now, we are in a devolved system, which has clearly failed. Number one, we copy-pasted our constitution in that aspect from South Africa in terms of the devolvement. What we forgot to do is copy-paste the amendments South Africa made when they found out. Then they had, theirs it was not devolved to counties, it was to provinces. When they found it does not work, and has not worked.
Sorry, sir, if I could just ask, what exactly in that devolution has not worked?
What do you mean, what exactly has not worked?
Yeah, you made a blanket statement.
Earlier on,
Yeah.
Professor Ogo was telling you there's money. Constitution, I mean, the counties don't get money until very late. What he didn't tell you is the reason. Reason being that County A was given money, and before they get another tranche, they have to account for what they received. That is where the problem is. Then the second problem, devolution is against the Constitution, if you ask me. It states everybody has a right to health at the highest and most affordable. Clearly, devolution has shown it is not affordable. And that's the question I want you guys to answer there. We can no longer continue following a path because a path has been followed, because we can't force issues of devolution when it is not working. Thank you.
Thank you very much. Try and paraphrase that. There are major challenges in how devolution has actually panned out in terms of healthcare service provision. So what does that actually mean, and what can we do to change the current paradigm? If we could get the second question, then we could have the panel answer both of them.
Yeah, thank you. My name is Dr. Stephen Ojwang from Premier Care Hospital Group. I'm a radiologist by profession, and thank you for this platform. I think they're very salient points that have been raised. And I sit here, health entrepreneurs' point of view. And I like what Prof said earlier, especially as regards to healthcare provision within the country. Why would you have, I like that point of why would you have within 2 square miles, you have so many facilities, yet in the peripheries, you don't have people served. And I like what Dr. Abdi said. So we are those people, they are health entrepreneurs who, like Dr. Abdi, have gone out there, try to make a difference. We run diagnostic centers, and when we first went to Garissa, people asked us, why are you putting a CT scan in Garissa? And the reason was people are traveling very far to get quality care. You've left the surgeons in a peripheral town. By the time the patient gets to Mwingi on the way to do a scan in Nairobi, they're probably not there. They're already gone. And the need for being able to get a diagnosis and being able to have the people then within those counties being able to do that was definitely there. And for that reason, we took the risk on behalf, I would say on behalf of the government, because technically speaking, ideally that is an entity that is an aspect that needs to be shouldered by the government. The question is, for that entrepreneur going to that space, and I like this discussion, what's the incentive for them? Is it that, do you slap them with a 16% tax on the equipment that they're going to invest in there? So it's food for thought. The other thing is that there's a lot of potential for healthcare, and here I'd bet to disagree with my colleague. I think there's a lot of opportunity for investments in healthcare in the underserved areas. Because yes, Kenya, we have made a few steps ahead, but we need to help our colleagues and neighbors in the East African community to be able to make steps as well in terms of where we are as a region. Because there are still opportunities for investments within the East African region that if we put our heads together, we can still be able to, I know the figures that were mentioned were scary, but if we put our heads together, have consolidated platforms as healthcare workers within which, or health entrepreneurs within which we're able to organize ourselves and absorb these resources that are coming, then I think there are opportunities for that. And maybe to answer the question, why is the money not finding a place to settle? The reason is largely, I look around the room and there are probably not many healthcare entrepreneurs in the room. Why? because they're busy in their clinics, running around trying to see, okay, it's almost end month. Yeah. We need to be there and pay bills. I need to work harder so that I'm able to pay the bills. But I'm glad that we have platforms like Strathmore, which has empowered healthcare professionals, for example, to be able to run and manage the businesses. Because the truth is, back in college, you're not taught how to run money, how to manage your finances, for example, as a healthcare professional. So there are unique opportunities, and I'm glad you are bridging the gap in being able to meet the needs of our communities and our region, because we are the ones who know the solutions. And unless we come out and also avail ourselves to be able to absorb these opportunities to access finance, then it may be in futility. My last point is that it's good to hear about ROI for the investors, and I'm glad that we have sort of a cocktail. The ROI is good and the opportunities for that, but also, more importantly, even as we invest into healthcare, we should also look at increasingly the social impact. Because why would I get incentive, for example, to do a diagnostic center in Loitoktok, which we have done, simply to save the people from traveling all the way? So it's not always about the money, yes. There may be other income generating units, but give us a platform whereby we can be able to also serve people who may not be able to afford, so that we have a blend of the two. Yes, you want your return on investment, but how then are you able to also serve the community and meet a need? Because that is really the reason why you were first called. But yes, I believe there are opportunities for investment in healthcare. So please don't go back with your money.
Thank you very, very, very much. Just to pick up on your last point about how do we get people out of the 2 square mile and incentivize them to actually go outside Nairobi, outside even the center of Kenya, which is Nairobi, Kiambu, and to the rest of the country, and that conversation about who is overseeing the ecosystem was even asked in the very first panel. There seems to be this overwhelming need for an ecosystem overseer. And this is a conversation that has been gaining traction. And hopefully in the next few months to years, with the help of institutions like Strathmore University and the Presidential Delivery Unit, we should start seeing some changes in the way the ecosystem is actually viewed and steered. That being said, I would like just to very quickly give only 2 members of the panel, that is Waiganjo and Abdi, yes, Daktari, a chance to, in 30 seconds, each of you, what can we do right with this devolution question? 30 seconds. Waiganjo first, go.
Thank you. Daktari. Thank you. We are voting in the next 78 days. We're going to the polls.
Yes.
Imagine no one is talking about health. No one is talking about health. They are putting their manifestos, but I want to give thanks to coalitions for health research and development, because there's a strategy to engage the I don't know whether they'll engage the 46 of them or the who successfully submitted, but the 2 main coalitions, so that then healthcare, before they get their and I think that's the way to go, because then healthcare becomes part of the agenda for any government that comes into power.
Thank you. In other words, we are throwing it back to you. Please get the governors together for us here after the elections. Bring them here. We'll talk to them, and we'll see how we can try and change that narrative. Abdi.
It's not all failure. The people who will say it has failed are the people who used to benefit from central government. If you look at keenly, there are counties who, for the first time ever, have consultants. And there are counties who, for the first time ever, have healthcare workers actually working. I will give you an example. Wajir, as I have always said, they have trained dialysis nurses, and they have almost 15 dialysis nurses working for the county. That would have never happened when health was not devolved. So it's not all failure.
Thank you very, very much. And on that very optimistic note, sir, you have something absolutely burning?
Yeah, I was just going to say that devolution actually it's working a bit. What we haven't fully done is that the center has not fully released it, so that it is a complete responsibility of the ACREC, the devolved unit. When that happens, because a lot of the funds that we have for the health sector are still at the center here. They have not been devolved to the unit that we are talking about, the county itself. When that happens, I think we shall see a different story. And I don't want to be political about this, but I think we need to convince the future forthcoming government that we have some changes in law. I'm talking about the overarching law, the constitution, so that we have the health sector fully devolved, and the way it is supposed to have worked. I don't know why I think we have somebody from the Ministry of Health here. We don't need to keep the processes of implementation for healthcare delivery services at the top. They should be right at the bottom. I like what my friend from Amrefa said, actually, that in fact, these coalitions that we are having, and most likely which are going to win the next election, we should start interrogating them, actually, where they place health. But we are hearing things like Baba Care, and that gives us an indication that somebody is thinking about what he or what they want to do if they win the election. So that's good. Regarding again bringing services, healthcare services closer to the people, I believe that should be, in fact, the role of the public sector, whether it is devolved government public services. If you can go and put facilities and things like utilities closer, people will move. Like, let me talk about Northeastern. The way to attract, actually, private sector money into Northeastern, and I, in fact, said this to one of the former ministers who was in charge of Northern Kenya development. He called me to his office to ask me, how can we bring private sector money to Northern Kenya? I told him, private sector is very good at looking at an opportunity, seeing an opportunity, and they can actually go quickly, put their money in that opportunity. But to see that opportunity, there must be some kind of a demand. So how do you create a demand? You create a demand by Northern Kenya actually making sure that you have those services that the general population there needs. Water. If you can, in fact, I told him, put most of your money, which you have been given by the budget, into drilling boreholes. You have very many water points in Northern Kenya, and then those nomadic tribes will move to where those water points are. Of necessity, they will go there. Where they start those settlements around where the water points are, the private sector will see there is a demand there for maybe housing. There is a demand there for maybe, a health facility. They'll come in there and invest. I told him also, go there and do a couple of airstrips where some private investor can come from Nairobi and land in Wajir or Mandera or somewhere with those planes which are in Wilson Airport, so that he doesn't have to drive 2 days. That time they could drive 2 days. Now they can drive in a day because we have this superhighway among the part of the LAPSET programs, which is going all the way to Mayale. So that in itself makes now that road, in fact, it was a desert, but now is an economic development corridor, and settlements are taking place. I know that because there is a program we are doing with the LAPSET that settlements are taking place when you deliver some of these support services. And support services is infrastructure and utilities And then somebody will come in and put in money, whether it's a health center or something of that nature. You have brought health care delivery service closer to that 2 miles you want. But it requires planning and knowing clearly that you want to attract that private sector money. If it is private sector money you need. Thank you.
Thank you very, very much, Charles. It was a pleasure interacting with you over the past 1.5 hours. And with that, ladies and gentlemen, I'd like to hand over the session back to our MC. Thank you, gentlemen.
So, good afternoon, ladies and gentlemen. A round of applause. A better round of applause, ladies and gentlemen. So, thank you so much for that panel session. We'll be shortly breaking for a small branch session, and I'll request you, as you go for the branch, kindly pass through the booths, then go to the branch. So just pass through the booths, through the exhibition booths that we have, then have a meal. So at this point, I'd like to invite Dr. Anastasia to give one as an announcement as we proceed.
Well done. Sorry, yes. So just very quickly, tomorrow after the Global Fund Roundtable, East African breweries will be bringing drinks. So we will go to the tent, as also we take an opportunity also to walk through the tent. What are they called? The booths, yeah. But this afternoon, we've been requested by the booths guys that we do a nice tour as we go to the lunch place. So if you could kindly follow the KHF team, the Open Fences team, and Strathmore team, just do a round, and then we go to the lunch area. But remember, tomorrow, don't leave. 3 p.m. we have the cocktail drinks from East African Breweries, or EAPL. So thank you very much, and enjoy the rest of the afternoon.
All right. Thanks a lot. We'll be back by 15 to 3. Yes?